नमस्कार, मैं डॉक्टर ऋषि कुमार सक्सेना, चेस्ट स्पेशलिस्ट, डिप्टी स्टेट टीबी ऑफिसर या उप राज्य क्षयरोग अधिकारी। आज मैं आपको ट्यूबरक्लोसिस या तपेदिक या क्षय रोग के बारे में अहम जानकारियां दे रहा हूं। जैसा कि इसके बारे में मैं बताना चाहूँगा कि ट्यूबरक्लोसिस आज की बीमारी नहीं, बहुत पुरानी बीमारी है। हमारे वेदों में भी इसका जिक्र हुआ है। हमारे यजुर्वेद में भी एक राजा सोमा थे जो यक्ष नामक बीमारी से प्रभावित हुए थे, जिनको बाद में राज यक्ष्मा कहा गया। इसका अर्थ होता है सूखा रोग। चक्रता संहिता में भी अगर किसी व्यक्ति के ट्यूबरक्लोसिस के साथ 11 लक्षण होते थे तो उन सभी 11 लक्षणों को पहचानने वाले वैद्य को राजवैद्य कहा जाता था। जैसे कि हिपोक्रेट्स ने इसके बारे में ईसा पूर्व ही बताया हुआ था कि इसको हम बोलते हैं थीसिस, का मतलब होता है कंज्यूम, यानी कि वेस्टिंग अवे। J.L. सोचन प्रोफेसर जो थे हमारे, उन्होंने एक वर्ड कॉइन किया इसको एस ट्यूबरकुला मतलब लंप यानी कि गांठ। उसके नाम से ये ट्यूबरक्लोसिस नाम से ये इसके बारे में बाद में इसके बीमारी को कहा जाने लगा। रॉन्गटन साहब ने एक्सरे का आविष्कार किया जिससे हम फेफड़े के एक्सरे देख सकते हैं। अब आप देख रहे हैं कि हमारे जो वैज्ञानिक थे रॉबर्ट हरमैन कॉक, उन्होंने 1882 में 24 मार्च 1882 में इस माइकोबैक्टीरियम ट्यूबरक्लोसिस बैसिलाई का आविष्कार किया और इनके नाम से 24 मार्च को अब हम विश्व क्षय रोग दिवस मनाते हैं। हर क्षय रोग दिवस का एक थीम होता है और आप देख रहे हैं कि 1997 से हर साल हम इसको मनाते आ रहे हैं इस दिवस को, और 2023 का जो थीम है वो है यस वी कैन एंड टीबी। ट्यूबरक्लोसिस किसी भी व्यक्ति को नहीं छोड़ता है, चाहे वो किसी ओहदे पे हो या कोई राजनीतिक हो या कोई पत्रकार हो। जैसे कि आप देख रहे हैं जो हमारे वैज्ञानिक थे जिन्होंने स्टेथोस्कोप बनाया वो खुद इस बीमारी का शिकार हो गए। 45 साल की उम्र में वो इस बीमारी से चल बसे। उनका नाम था रेनी थियोफिलिन हेंथी लिनेक, जिन्होंने स्टेथोस्कोप का आविष्कार किया था। इसके अलावा हमारे कई स्टेट्समैन जैसे कि मोहम्मद अली जिन्ना, नेल्सन मंडेला और श्रीमती कमला नेहरू जी स्वयं टीबी की बीमारी से ग्रसित हुए। हमारे मैथमेटिशियन श्रीनिवास रामानुजन, जिनके नाम से हम इंडिया में मैथमेटिशियन डे मनाते हैं, वो खुद इस बीमारी के शिकार हुए। कई आर्टिस्ट ऐसे हमारे सुपरस्टार अमिताभ बच्चन, वो इस समय ठीक हो गए हैं, पूर्ण तरह ठीक हो गए हैं। और विवियन लीग, जिनको ऑस्कर अवार्ड मिला था सन 1962 में, वो भी टीबी की बीमारी के शिकार हुई। हमारे एक हरमन बर्मर साहब ने सैनिटोरियम का आविष्कार किया और आप देखें कि बुहाली में जो है 1912 में सैनिटोरियम का आविष्कार हुआ, जिसमें श्रीमती कमला नेहरू जी भर्ती रही थी वहाँ पे, और इन्हीं के नाम से अब वहाँ पे जो सैनिटोरियम इंस्टीट्यूट है वो श्रीमती कमला नेहरू इंस्टीट्यूट के नाम से रखा जाता है। अब आप देख रहे हैं कि सन 1500 ईसा के बाद से अब तक 2023 तक हमने कई खोजें और कई आविष्कार किए इसके बारे में, जो आपको धीरे धीरे हम बताते रहेंगे क्या क्या हुए। एज यू आर सीइंग 3 slides here. One is from ordinary microscope, other is by fluorescent microscope, and third is by electron microscope. Here the bacilli is banana shaped, which measures about 2 to 4 microns in length and 0.5 microns in width, and it is acid fast bacilli because of its lipid cell wall, which resists the declination by 25% sulfuric acid, and hence it is called as acid fast bacilli. The other slide which shows fluorescent type of it, which it can be easily seen at the by fluorescent microscope. The third slide shows is shown by electron microscope, which here they are looking quite big, and it is used for research purposes. The AFB from the ordinary microscope and from the fluorescent microscope can easily be seen in all the labs which are located in primary health centers and community health centers and even district hospitals also. When a person coughs, the large droplets, they fall immediately. The 1 to 5 macrons, they stay and they reach the alveoli. When a patient coughs and that mycobacterium which is crystallized in that part of the sputum, it is inhaled by a person who is non-infected with TB. When a person inhales it, that bacilli enters into the alveoli of the lung, and the first interaction is by the first our defense mechanism by alveolar macrophages. Now, what does it do? It binds Mycobacterium tuberculosis in three ways. Number one, the terminal moieties, mannose moieties on MTB binds via mannose receptors which are present on the alveolar macrophages. But there are two, binds with MTB via complement C3b proteins which are expressed on MTB via complement receptors. Now, these receptors are present on the alveolar macrophages. And recognition of antigens on MTB by pattern recognition receptors PRR present on the macrophages. So, by all means, MTB is entrapped by macrophage, and when it does so, that phagosome, it entraps it, alveolar macrophages entrapped it, and it is now called as endosome. Under normal conditions, alveolar macrophage activates its internal tubular system, which activates further lysosomes to combine phagosomes which has acid hydrolases, proteinolases, DNases, which cause influx of H ions in the phagosome for acidification, and hence it is called as acidification of the lysosome. So, it is called as a maturity of phagosome or phagosome-lysosome fusion. But here comes the end point, is that macrophages changes the the overall scenario of that area by inhibiting the acidification. So, the lysosome and phagosome fusion doesn't happen, and it alters the pH also. It inhibits the waste proteins also. So, maturation of the phagolysosome is not going to happen, and patient is now infected with MTB but not having disease. So, immune suppression by macrophage tuberculosis is by three mechanisms: inhibition of the phagosome maturation, phagosome acidification, inhibition of phagosome lysosome formation, inhibition of interferon production. Now, what is the reason for inhibition of phagosome with lysosome is that for fusion to occur, phagosome has RAB5 protein on it, which exchanges with RBAB7 protein, which in turn causes initiation of fusion of phagosome with lysosome. But encapsulated MTB recruits RAB22, which prevents exchange of RAB5 to RAB7, and which further prevents the phagosome fusion with the lysosome, as you are seeing in this slide. Besides this, what does MTB do? MTB releases PTPA protein trionase phosphatase, which binds with subunit H of the ATPase, which inhibits the activity of VATPase, which further inhibits the acidification of the MTB. There is another TACO protein on phagosome, which detaches and leads the delivery of phagosome towards lysosome for fusion of both, but MTB prevents the detachment of the phagosome towards lysosome, and hence it delays fusion. Besides this, there is another C gas molecule, cyclic GMP in macrophages, which detects foreign DNAs from degradation pathogen from phagosome, which activates sting pathway, which causes interferon production. But here, as you are seeing, all these pathways are blocked. As a result, there is inhibition of the production of macrophages. In some persons, the genetically proteins are also there, which helps in fusion of phagosome with lysosome, but in genetically diseased person, this is also not happening. Now, alveolar macrophages has lost all its attackers and defenders, and so it acts as parasitism to MTB. As now it is a home for MTB, which in turn releases and replicates. And when full macrophage, it bursts and it releases all its pathogens. Its antigens are released into the alveoli, interstitial spaces, it goes into the blood and in lymph nodes. So, MTB has now infected humans. This period takes till to total of 21 days, or we call it at 3 weeks. Since MTB is an intracellular pathogen, so there is no role of B cell or humoral immunity, as macrophages are found in extracellular fluids. Now this macrophage in turn releases IL-2, IL-12, which binds with T cells, we call it CD4 cells, which in turn activates, and this releases IL-2, which causes multiplication and proliferation of CD4 cells. As a result, in the lymph nodes becomes enlarged. This CD4 cells releases further gamma interferon protein, which activates macrophages to release TNL alpha, IL-1 and IL-2, which causes fever and loss of appetite to the patients. Chemoattractants also comes, which surrounds the macrophage, the MTB, and so that is MTB is surrounded by all the chemoattractants, and then more and more T lymphocytes come via nearest blood vessels. This macrophage releases oxygen reactive species. So a war starts between MTB and macrophages at T lymphocytes. MTB does not like fatty acids, so it runs away from it. And here, which we are seeing in the slides. And so macrophage, being aerobic pathogen, does not grow as it is slow growing bacteria. It takes 12 to 15 to 20 hours to replicate, and hence it tries to run away from here. So this all constitutes the, we call it as a chrystic granuloma. But granuloma is not a diagnosis of TB. It may occur in variety of other infections, as you are seeing, like bacteremia, sarcoidosis also it is seen, and other bacteria also seen. Now granuloma is a macroscopic structure, but when it collates together, it becomes cheese-like constituency, and it is called as Gons focus. When many macroscopic granuloma collates, it becomes Gons focus. And if same thing happens in the lymph nodes, then it constitutes the Gons complex. And when it is seen in the X-ray, it is called as a Ranke complex. This granuloma may lie dormant for years and gets reactivated again in patients whose immunity is low, like have HIV, with diabetes, long-term use of corticosteroids, anti-cancer drugs, patient on dialysis, and some patients have genetically impaired this protein, which delays the fusion of phagosome and lysosome, as I have informed you earlier. So this becomes activated. Macrophage cannot do anything. Infestation, it kills pathogen. It cannot kill itself. Outside cells also cannot kill macrophages. Activation and working of macrophages is not going to happen. MTB proliferates and waits till the immune system is weakened, and then it erupts like a volcano erupting. In both the cases, the granuloma is activated, and which occurs mainly in lower and middle lobes. And when it is seen in X-ray, it is called as Ranke complex. What is the classification of tuberculosis? Based on the sequence of events following the first exposure: primary TB caused by MTB with no previous exposure, progressive primary TB disease which is self-limiting and will progress to larger lesions, post-primary TB, secondary TB. Based on location, we have pulmonary TB or extrapulmonary TB, disseminated TB involving more than two non-contagious sites. Disseminated TB can occur in primary, generalized TB, and post-primary form of diseases. When the lesions are uniform and the size of millet seeds, the term miliary TB is used. primary progressive TB and secondary progressive TB. Post-primary TB, here you are seeing primary TB, disease caused by MTB with no previous exposure or Gons complex. Progressive TB, you are seeing primary TB which is self-limiting and may progress to give rise to larger lesions. Post-primary TB or secondary TB, which is reinfection or reactivation, especially in the upper lobes. Chapter 3, Epidemiology of Tuberculosis, India in contrast to global scenario. As per the latest tuberculosis World TB report, which is released every year in the month of October, now 2023 report shows that the maximum highest number of cases of TB are in India. And though there is a decrease in the number of cases as compared to 2015, as we are taking it as a baseline, here you see there is a decrease of 10 to 19% of cases in India of TB as compared to the baseline of 2015. The number of MDR TB is also highest in India. As you are seeing here, the largest circle occurs in India. The countries where the notification and the prevalence is there is also highest in India, means that there are many TB cases which are being missed. So missed cases are also maximum in India. Here comes the role of National TB Elimination Program. How do we track these cases and treat these patients and put them in our system? India accounts for 2.9% of the MDR cases of the world, with no previous history of TB as per the global report of 2022. Now, WHO also shows there is a decrease in 20 and 21 also. Global reduction is there, it was there because of the COVID, but recovery is seen in India and Philippines and Indonesia. 8 countries of all the countries accounts for 68% of the total tuberculosis, and India constituting about 26% of the TB. Here we see that there is a reduction of 10 to 19%. You are seeing here. Death has also been reduced in India about 6 to 19% as compared to the baseline of 2015. So 71% of the global gap is seen between the reported cases and the incident cases. 10 countries, here also the maximum gap is seen in India, the missed cases I would say. So about 14 countries are there which have highest number of MDR cases, highest number of TB cases and highest number of TB and HIV cases. Now you are seeing this slide as a global versus India burden. India accounts about 27% of the global TB. The mortality of TB is 29% of the global world. 7.2% have TB with HIV. 6.6% of mortality is in TB with HIV. 27% of the global MDR cases are in India, and 25% of the global children in India are suffering from TB. In UP, we have the UP constitutes about 21% of the total India cases. Means that 1/5 of the TB cases of the whole of the India are present in Uttar Pradesh. Now notification, I would say, means that those cases which are notified, which are informed in our government system, are 258 per lakh as per the data of 2023, and expected cases were in UP has now crossed, which are being notified in our system, is 6.27 lakhs. In 2023, 6.27 lakhs were reported against the target of 5.50 which was given by the government of India. And the reported cases were, as you are seeing here, in HIV positive 0.5, drug resistant TB 3%, 62% patients are in bread earning livelihood days. It means 15 to 45 years. Urban has 22% of the cases because of more of the facilities. Early diagnosis is there. And rural, there is we are focusing on the rural part also because 78% of the patients still live in the rural areas and their delay in diagnosis and treatment is an issue. As a result, more cases are being present there. Our Honorable Prime Minister on 24th of March 2023 and previously 13th of March 2018 has committed two things. In 13th March 2018, Honorable Prime Minister launched Delhi End TB Summit. The campaign calls for a social movement focused on patient-centric and holistic care by integrated actions for TB-free India. Then, on 24th March 2023, Honorable Prime Minister launched TB-free Mukt Panchayat initiative. Number 2, short new or oral regimen, a new shorter regimen for TB preventive therapy and release of extrapulmonary TB guidelines also, which will be shown in there during addressing One India, One World TB Summit. Commitment by Honorable Prime Minister is by 2025 we have to eliminate TB so that it from 34 deaths which were in per lakh population to reduce to 3 per lakh population, means 90% reduction in deaths as compared to 2015, 80% reduction in TB incidence as compared to 2015, which were 217 to 44 per lakh, and catastrophic cost must be zero starting from 2020 onwards, means free diagnosis, free treatment, and we are also giving 5 rupees 500 as Nikshay Poshan Yojana to the patients till patient is treated by free of cost by the anti-TB drugs. The National Prevalence Survey, which was conducted in 2019 and 2021, shows that India has 316 microbiology confirmed cases which were above 15 years of age, and UP has 481 cases per lakh population. Here, so what we did was that we have to screen patients, and the target was 2000 per lakh we have to screen patients in UP, but we have reached to 1298 from 801 with an incremental increase of 400 cases per lakh. Now our target is to reach 2000 cases per lakh, and out of this 257 cases were reported, means from screening of 1298 cases we screened and we got 257 cases notified confirmed pulmonary cases. Now we have 4 national institutes you are seeing and 1 state institute. Chapter 4, Lab Diagnosis of Chest Infections. Here is the timeline is shown of various TB diagnostic, what are the diagnostic and from which year they have increased and now where we are. So there are 3 types of diagnosis: active tuberculosis diagnosis, which is smear microscopy, the CB-NAT, the NAT, we call it true NAT or the CB-NAT, and by the liquid cultures. Now WHO endo tests are what? They are LED microscopes which have some advantages and limitations. The CB-NAT, which also has the advantages and limitations, but CB-NAT is or true NAT is present in all the primary health centers, community health centers and district hospitals. And we have the cultures which are present in labs which are intermediate reference laboratories. Interference regional labs we have in Lucknow, we have in Gorakhpur and other cities also. So how do we collect the samples? We have 2 types of TB, the extrapulmonary TB and the pulmonary TB. Extrapulmonary TB depends in which organ it has, and from there the sample is collected, and in pulmonary TB the main sample is the sputum. So Collection of extrapulmonary samples can be spinal, from pericardial, from pleural, from synovial fluid, from ascitic fluid, but samples should never be collected in formalin, and no preservative should be added for any extrapulmonary samples. Now, transportation of these samples is done to the labs also, and we have detection for TB detection. There, which sample should be taken from extrapulmonary and pulmonary. For pulmonary, we take sputum. For extrapulmonary, if lymph nodes are there, we do the lymph node biopsy or aspirate it. We tap the pleural fluid. We do the pleural biopsy. We do the ADA also, adenosine deaminase test, and we also do the CBNet and TrueNet of pleural fluid. CSF, we can take it and we can do the CBNet and TrueNet. Other parts of the body also we can take the samples, as you are seeing here. So, the diagnosis of extrapulmonary TB is microbiologically confirmed or histopathologically, and also by the CT scan or X-ray test also. Now, these are the diagnostic modalities. As you're seeing, the microscope, the CBNets, the culture machines which are present in IRLs, and the microscope and CBNet, TrueNet and X-ray are present in primary health centers and community health centers. Culture is also being done, which is present in the culture and dust sensitivity labs. Now, we compared that, since we say the culture is a gold positive standard, what is the sensitivity and specificity of the NAT? We are seeing that all culture positive by NAT machines, they show 92% positivity, sensitivity and specificity of 99%. So, a high sensitive test means that there are chances of few false negative tests, and so few cases are being missed. A high specific test means that there are chances of having few false positive tests. So, very rare they are being missed. What is the accuracy of CBNet of the samples like CSF, lymph nodes, pleural fluid, gastric lavage? We are seeing that specificity is 98%, 94%, 99% and 98% respectively. So, this graph shows that sample transportation from patient, that sample should be reached to the NAT site within 48 hours, and via where they are Far East Asian areas, the samples are, we have a MOU signed by the postal system, through which the sample is taken by the postman, and here the samples are being taken to the intermediate reference labs. These are the metals required for transportation. Technical specification, how the sample is being taken and in which box it is taken, it is being shown here. It is in a thermocol box which have ice-gel packs, and where the biomarker sticker is there, biohazard sticker is there, and the samples are being taken in a Falcon tubes. Turnaround time, when the sample is being taken and when the results comes of the report comes to diagnosis, is being indicated in these areas. What are the time taken, how many days it should take from NAT to the treatment started by the patient, and all these are areas which are showing that NAT, LPA, liquid culture DST and follow-up cultures. Chest X-ray is also used here. It is mainly used for the diagnostic. It is not used for the diagnostic, it is used as a screening tool when we screen the patients. As a triage tool, X-ray, chest is used as a triage tool. How do we know where the patient is having this? If a patient is not coughing but has symptoms, we take the X-ray. And if the X-ray shows opacities in the areas, especially in the upper areas or anywhere in the lungs, we can say that patient is of having presumptive TB disease. Or if, then we send the patient for the sample. And if the patient's sample comes and is positive, then it's confirmed TB. Otherwise, as per the clinical equipment, even a physician can also diagnose it as a clinically diagnosed TB. Now here you are seeing the probabilities of false positive and false negative when chest X-ray is combined with number one, by the symptoms of the X-ray, by the CBNet, by the microscopy. Here you are seeing the green ones are the positive part and the red plus are the negatives. Here you are seeing how much which constitutes what. Now we come to the organogram, chapter 5. Now we come to the organogram of the tuberculosis, National Tuberculosis Program. What is the hierarchy of the system? Here we work, NTP works. Ministry of Health and Family Welfare, Government of India has a central TB division, which has 4 national premier institutes and which have a national committee. Then we have a state, in every state there is a state TB cell which has a state TB officer, a deputy state TB officer and its staff, training staff, which is called as State Training and Demonstration Center, STDC. In UP we have in Agra. Now we are opening also in Lucknow and in Gorakhpur also. Then at district level we have district TB centers. Below district TB centers we have in blocks, we call it as a tuberculosis unit. We have tuberculosis unit, and below it in primary health centers we call it as designated microscopy center, where by microscope we can confirm patient is sputum positive or negative. This is present in the peripheral microscope centers. And below it now we have health and wellness centers which are operated by the community health officers, CHOs. So we have seen this is the organization structure. State level we have a health minister overall, then principal secretary, medical health and family welfare, MD NHM, managing director NHM, and director general health and family welfare. They are the two modalities. Then MD NHM and below MD NHM and director health and family welfare is a state TB officer and deputy state TB officer. And below it are state TB cell, then nodal DRTB centers, STDCs, and intermediate reference labs and culture and DST labs. Below districts we have district magistrate, the CMO, the district TB officer, the TB unit, the DMC. Previously it was called DMC, Designated Micro Center. Now it is called as Tuberculosis Detection Center, TDC. And below it is we call it a treatment supporter, which peripheral health institutions, and below it is a treatment supporter. Now we have, regarding lab networks, we have 2061 microscopies done in various parts of the blocks of the districts. In UP, 166 CBNet labs, 731 TrueNet labs. We have one national reference lab in Jalma in Agra, and we have 2 labs, as I have told you, in Lucknow and in Agra, and upcoming labs 3 are approved in BHU, in Gorakhpur and Meerut. Existing labs, so we have 8 now. Culture and DST lab we have 8, which are, as you seeing the red dots. We are seeing 8 in India, in UP, and we have 2 newly proposed are in JIPS Noida and in SGPGI. Nodal DRTB centers we have around 24, and one has recently started in RML Lucknow, and 2 are also proposed are in SGPGI. One is proposed in SGPGI. UP being a big state, we have divided 700 districts into 5 regional program management units. We call it as RDPMUs. So you are seeing that in Agra, it is divided in 5 RDPMUs: Agra, Bareilly, Lucknow, Gorakhpur, Banaras. Here you are seeing that how many districts are linked to those RDPMUs. Agra has 17, Bareilly has 18, Lucknow has 19, Gorakhpur has 10, Banaras has 11. These are the headquarters of the RDPMUs. Now, what are the myths in TB, in treatment and diagnosis? This is very important because most of the doctors, especially the private practitioners, they don't know about it and they start giving ATT based on these myths. Number one is ESR. Elevated ESR is a diagnostic tool. No, it is not a diagnostic tool. As here you are seeing, it is written mainly in a general, because these slides will be taken from general. It shows that an elevated ESR may be expected in children with tuberculosis, but it may be normal in 1/3 of the children also. So there is no role of ESR in diagnosis of TB. Montus test is a diagnostic tool. No, it is not a diagnostic tool. It can be used as a screening tool also, because it detects infection and not disease. There is a difference between infection and disease. A person may be infected but may not be having disease. If we say like this, that Indian population, about 40% of the Indians are having Montus positive, means that 40% of the Indian citizens are infected with TB, but they are not having disease. This is the main thing. Opacities in the X-ray is considered as a diagnostic tool. No, it should be used as a screening tool. TB Gold, a new test which have been shown that it is serological test, but it also detects infection and not disease, and it is a banned test as by the Gazette notification which came in 7 June 2012. If diagnosis not confirmed, give a trial of ATT. No, we should give ATT only when you see there is a clinical history presentation. If there is a loss, all the presence history is there. There is an index case. Patient is a contact of index case. There is tuberculosis skin test is also showing positive. Chest X-ray, if available, is there. Bacteriological confirmation is there. Then issues are solved. But still, if it is not there, then any history relevant patient is maybe having HIV or any other comorbidity, or patient is having suspected extrapolar TB also if sputum is not coming. So in this case, we can say then we have to give ATT only, and not a trial of ATT should be given. We have to give either full course but no trial. Some physicians, they start giving fluoroquinolones. We should not give fluoroquinolones because it masks the infection of TB. And when we are giving fluoroquinolones in our multi-drug resistance TB, there are chances that those patients who had taken fluoroquinolones before, during any type of illnesses, they might be resistant to that fluoroquinolones. Now, what are the gaps in the services? Why is a delay in that region in the having the symptoms and taking the treatment? A study was done, and we found that in government system there was less gap, but in private there was more gap, as you are seeing here. From onset of symptoms to first consultation, the gap was 25 days on an average in a government sector and 29 days or 30 days in a private sector. From first consultation to diagnosis also, that in government it was quite less, about 10 days, although this slide data is of 10 years back. I'm talking now. We can diagnose it within 2 days, or within a day we can diagnose it, and we can start the treatment on the same day. So here are you seeing that the treatment initiation is also quite delay here. Now a study was done how many practitioners know the correct regimen of giving the drugs in a case of multi-drug resistance TB. Now here you are seeing out of 106, only 3 practitioners knew the correct regimen of multi-drug resistance therapy, because most of the doctors are not being trained in the private doctors are not being trained, and government policy is to train all the doctors. So a CME is being done. We regularly perform the CMEs for all the private sectors. We are already doing for the government doctors, but we also do it for the private sector so that they can be also updated in the latest National Tuberculosis Elimination Program guidelines. Now, what are the determinants of TB? You are seeing this is a global world TB report. Here shows number 1 is undernutrition, HIV infection, diabetes, smoking, and alcohol use disorders. Now, the global TB report of 2021 shows the deaths which were having by COPD, diabetes and TB also is number 3 as per the Global TB Report 2023. Old age also constitutes the determinant of TB. The dose response, when the BMI is low, yani body mass index is low, when one decrease in BMI constitutes to around 14% risk of having TB. COPD is also a risk factor for TB. Then slums, poverty, overcrowding, as you are saying, the old age homes, the ashrams, vridhashrams are areas where we get maximum number of TB patients. What are symptoms of TB? What are the symptoms of tuberculosis? The symptoms are cough lasting long for 2 weeks, loss of appetite, loss of weight, previous history of in past 6 months of having hemoptysis, pain in chest and night sweats. These are the main symptoms of. We do the screening of TB from the ground level, starting from the ASHAs, ANM, CHOs to higher level also. Now here when we say a patient is sputum positive, how does a patient gets infected? Here you are seeing that these are symptoms. The contact of TB case patient, we call it an index case. There are 60%, 10 to 60 times more risk of having contacts of getting TB when they are in close contact with the index patient. So a study was done which shows that contacts of MDR TB are 70% of getting same MDR TB. The contacts here you are seeing the big circle is of index case and surrounding circles of the contacts here. So contacts are also being treated or being given isoniazid preventive therapy so that they may not have TB after ruling out the diagnosis. Now extrapulmonary TB also we have, which constitutes of 15% of the total TB. The AIIMS New Delhi has released its guidelines, standard treatment workflow of all the site extrapulmonary TB, which is also being circulated here. For added peripheral lymph node, here you are seeing these are the SOPs. For pleural tuberculosis, we are seeing the SOPs. For pericardial tuberculosis, we are seeing the SOPs. For meningitis also, we are seeing the SOPs. For abdominal tuberculosis or Cox abdomen, we are seeing the SOPs. For adult musculoskeletal tuberculosis, we are seeing the SOPs. For skin TB or cutaneous TB, we also have the SOPs. For intraocular TB, we are having the SOPs. For genital unit TB, we are also having the SOPs. Female genital tuberculosis, SOPs. So they are all the SOPs which these are the SOPs which are present, which are released this year only, and it has been circulated in all the books. And we also train all the doctors, private practitioners and government doctors also on pulmonary as well as extrapulmonary TB. In pediatric also we have pediatric abdominal TB, we have pediatric intrathoracic TB, we have pediatric lymph nodes TB, we have pediatric osteoocular TB, articular TB, and we have pediatric tubercular meningitis SOPs also. So treatment of drug sensitive TB. We have now fixed dose combination of drug sensitive TB. Here we give age-wise medicines, as you are seeing here in this table. Depending upon the age, when a patient is diagnosed and is having to start a TB treatment, we give, depending upon the age, we give number of tablets to these patients, as you are seeing in this table. From 0 to 18 years, we have also pediatric drug sensitive TB regimen, intensive phase consists of 2 months and 4 months of intensive of continuation phase. Then we also do the follow-up of every 6 months till 2 years, from 6 months after treatment to 12 months, then 18 months and 24 months respectively. Drug resistant TB management. This is very important because the new guidelines have been released off and on 2017, then 2019, and now 2021 guidelines have been released. I will be discussing on with 2021 guidelines. There are three types of drug resistance TB, or oral H monopoly DRTB regimen, shorter MDR regimen, or oral longer regimen. Now, these are the medicines which we give in all the three consecutive DRTB sessions. You seeing here in the slide. This is the I would say the pharmacokinetics of how the drugs act in a cell at a molecular level. All the 880 drugs how act. This is a study from the Lancet 2014. Here we are showing all types of drugs. What is the mechanism of action of these drugs? Now, gene expert also we are also doing, and which type of gene the gene expert machine detects. Here you are seeing that target region of each drugs: isoniazide, ethanamide, fluoroquinolones, kanamycin, all the fluoroquinolones. Then what is sensitivity and specificity through the drug sensitivity test? It is shown here in this slide. Line probe assay. Through line probe assay, we can detect which type of genes we are detecting, and which we can say if this gene is present, which means that patient is resistant to one of these drugs as shown in this table. Here also the same thing. It is more in detailed areas, which gene in INH are the target genes in rifampicin, in ethanamide, prothonamide, in levoflox, moxiflox, and aminoglycosides, I would say kanamycin, amikacin, and capromycin. Now the MDR drugs are grouped in category A, B, and C. The category A includes levoflox, moxiflox, and bedaquiline, and linezolid. Category B includes clofazimine and cycloserine. And group C, we have delamide, amikacin, pyrazinamide, ethanamide, PAS, mepenem, and these are the drugs which are seen in we have the mnemonic like DAS, ATU, PEC. It will be easy for us to remember. DAS means delaminid, amikacin, and pyrazinamide, ATU, ethanamide, PEC, PAS, ethambutol, and C, carbapenems. These are the weight bands of MDR drugs through which band we can give these drugs, as you are seeing in this table. Now, for every case of a DRTB, or every case, we have to take clinical history very thoroughly. What we have to take in these cases? Previous history of TB, history of contact, or previously ADT has been taken or not. Number 2, reports of diagnosis is available about adherence, monotherapy or treatment failure. Then any adverse drug reaction during treatment in previous treatment. What was the outcome of that treatment? Was any comorbidity present or at present recently, or is having like HIV or diabetes? Close contact of TB patients, status of counseling during treatment, and other issues. Now, as I have discussed, there are 3 types of DRTB. Now, first we go to the oral H monopoly treatment. These are the standard SOPs for the treatment. How do we monitor this case? What we do, if rifampicin is not detected, we do the first line LPA, and if first line LPA, as soon as it is detected, we start giving H monopoly regimen. For this, we do the pre-treatment evaluation, as you are seeing here. If no problem is there, then the treatment regimen is 6 months. But if any drug is showing any resistance, then the regimen is extended to 9 months. Like if levoflox is replaced by a moxiflox, treatment regimen is increased to 9 months. Doses, as here you are shown here. If levoflox cannot be used, we replace with moxiflox. Moxiflox cannot be used, we replace with linezolid. If both moxiflox cannot be used, now these are the replacement sequence which drugs we have to add when the previous drug is having resistance. Then when the treatment is started, we also see whether the patient is being benefited or not. We do the monitoring and systematic follow-ups, either monthly. Now, these are the durations at what time we have to do which follow-up. Like clinical weight, we have to take monthly at the end of treatment. Smear examination from month onwards till the end of treatment. Conduct smear microscopy at the end of 7 days if the previous smear is positive. So, to see the bacteriological conversion or reversion. Culture at the end of 3 months at the end of treatment, or 9 months or 6 months, whatever is applicable. Then NAT smear culture, if the previous culture is positive, we have to do again NAT or DST also. And urine pregnancy test in case of female, whether we have to start DRTB regimen or we have to abort, or we have to, depends with the consultation with the gynecologist. Now, these are the following follow-up monitoring evaluations also. H monopoly in children also, we do the management, same in adults, and child-friendly formulations are also available with us. Now, in pregnancy and lactation, the one thing is very important is that in drug sensitivity, pregnancy and lactation will continue as if patient is not having drugs, any TB. But in case of drug resistance TB, we have to see, because there are certain drugs which are teratogenic to the child also, or newborn child also. We have to see at what time the pregnancy is there and which drugs we have to use and which we have not to use. People living with HIV, as we know that in HIV, the mortality in HIV, 25% is constituted by TB. So, in all the case of HIV patients, we have to first monitor whether the patient is having TB or not. Number one, if patient is having TB, we have to give ATT first, followed by antiretroviral drugs 2 weeks after starting ATT. Number one. Number two, if patient is not having TB in a patient of HIV, we have to give a prophylactic isoniazid tablet for 6 months. In case of extrapulmonary TB also, we have to give the same. The duration is quite changed. In case of CNS TB, it is about 9 months. Now, we all know that all the drugs are causing adverse drug reactions. So, we should also know what drugs are causing which adverse drug reaction. So, this table shows the adverse drug reactions caused by which drugs. Coming to the shorter oral regimen. This is the SOP of shorter oral regimen, and which includes the drug bedaquiline. Now, the eligible criteria is that if the patient is having rifampicin resistant, number one, and patient is having either CAT-G mutation or INH-A mutation, but not both, and patient is also sensitive to fluoroquinolones, then in that case we have to give shorter oral regimen. In children also, we can give this from 5 years to 18 years, and the weight should at least 15 kg. It should be more than 15 kg, and there is no history of previous exposure to bedaquiline, levoflox, ethanolamide and clofazine for more than a month, and there is no extensive TB disease or severe extracellular disease even on the X-ray also. And women who are not pregnant and lactating, they can be included in inclusion criteria. Exclusion criteria, the reverse of it, we have the patients who are having both INH-A and RBO resistant, and also patient is resistant to moxiflox, and patient is having bilateral extensive pulmonary disease or cavity lesions are there. In that case also, and children below 5 years, they are excluded in this regimen. All the cases in pre-treatment evaluation also, we have to do the pre-treatment evaluation of all this. Here we have to take history, weight, and all the recommended pre-treatment evaluations for all the drugs should be done before starting or oral shorter regimen. Now, this is the regimen for 4 to 6 months. We have bedaquiline, which is given for 6 months, levoflox, clofazimine, pyrazinamide, ethanolamide, high dose INH and ethambutol. Then 5 months we give levoflox, clofazimine, pyazidamide and ethambutol. The treatment duration is 9 to 11 months, in which we have initial phase of 4 months, followed by extensive phase of 6 months and continuous phase of 5 months. Beta-glucan has to be given for 6 months. Treatment can be extended in case when it can be extended when the follow-up smear shows positive at the in following cultures. The treatment can be extended for 11 months also, maximum of 2 months. That's why we say 9 to 11 months. Additional criteria for using of beta-glucan in any regimen. Here you are seeing inclusion criteria, exclusion criteria. Doses of all the drugs or shorter oral regimen is being there. Replacement sequence. In shorter regimen, we don't use the replacement sequence. We immediately switch over to or oral long regimen when we see that the patient is not responding to any drug of or oral shorter regimen. So we have to replace it in a shift to or oral long regimen. And the monitoring and follow-up should be done properly as and when clinically indicated. And these are times where we have to do the follow-up. Management. Principles of management children also is same as we do here also. The child-friendly formulation is also there. Pregnancy and lactation, we have to see at what time regimen can be started, because beta-glucan containing regimen cannot be administered in pregnant women before 32 weeks due to ethanolamide teratogenicity in the first trimester and risk of hypothyroidism in second trimester to infant. Beyond 32 weeks, the choice of regimen needs to be consultative decision between the obstetrician and the physician at a nodal DRTB center. People living with HIV, shorter oral regimen can be used, and those patients who are having along with ART. Surgery depends on which type of lung, which part of the lung is being damaged, where it is needed or not, in consultation with the cardiothoracic surgeon. In renal impairment also, we have to see most of the drugs, they have excretion via kidneys, so we have to see which other drugs and what is the estimated eGFR, so that we can know which drug, what is clearance of it through the eGFR mechanism formula. We can know the doses of those drugs can be reduced or may not be given. Some patients may having pre-existing liver disease also. In that case we can start ATT. So all these guidelines are there, that what we have to do and what we have not to do. Patient with seizure disorders, adverse drug reactions. Then this I have been told that what is the additional monitoring of patients on shorter oral beta-glucan containing regimen. These are the things we have to monitor in addition to the patients which are on or oral shorter regimen. Side effects of all the drugs as shown here, also shown. We should know all these drugs, which drug is causing which types of symptoms. Coming on to the or oral MDR treatment regimen. Here the standard treatment flow of or oral long regimen is shown here. The pre-treatment evaluation also done in this case, and what is the basis of or oral long regimen is also shown here, which is 8 to 20 months of levoflox and beta-glucan along with linezolid, clofazimine and cycloserine. There is no separate IP and CP. Here we have to give all the drugs till 18 to 20 months. And if patient is having some resistance of these drugs, then here we use the replacement sequence, as I have informed you earlier. Then inclusion criteria and the exclusion criteria is shown here. Follow-up at what time and which follow-up has to be done is shown in these slides. How do we manage management of pregnancy and lactation during MDR-TB is also shown here. Pre-existing liver disease, role in PLHIV, renal impairment, and what are the doses which has to be done in the renal impairment and how much it is shown in this slide. Patient with seizure disorder, same. which what patients had a comorbidity in shorter oral regimen are same here in or oral long regimen, but with different scenario of treatment and follow-up and their additional pre-treatment evaluation. I pay my sincere thanks to Principal Secretary Health and Family Welfare, Director General Health and Family Welfare, and Director Administration Health and Family Welfare.